Hello, we want to get started. Hi, I'm Denise Juliano-Bult. I'm going to just be the moderator of this session. We have a jam-packed schedule, as you guys have all seen already. So we have actually 6 presenters, and we have 15 minutes per group. And if there's time for questions during the presentation, the presenter will signal that and let you know. Otherwise, hold your questions till the end. Our first presenter is Sarah Horowitz, who's going to be doing a presentation on sustainabilities of EBPs in community mental health settings.
Thanks, Denise. Good afternoon. I'm Sally Horowitz, and I'm going to talk about basically a long-standing New York State effort to improve the training of its mental health clinicians. Living a reasonably boring life, I have no disclosures, and the funding for this is, it's the truth. It's what happens when you work all the time. The funding comes from a grant from New York State to my colleague Kimberly Hoagwood. So, as many of you know, to close the gap between empirically developed evidence-based practices and usual mental health care delivered in community settings, and to meet the demands for restructured healthcare delivery systems that are supposedly paying for value rather than volume, many states have instituted programs to disseminate evidence-based practices to agencies and providers in their state systems. Training programs for existing mental health care providers are often an important focus of states' efforts to increase the use of EBPs. However, there are scant data on the actual implementation of these training efforts and even less data on the sustainability of training efforts, particularly in community mental health care settings serving children. A broad review of sustainability of innovative practices in multiple areas, including mental health, by Sturman et al. In 2012, concluded that the literature on sustainability was, and this is a direct quote, fragmented and underdeveloped. A more focused review of key findings from a systematic review of 73 articles based on 44 studies of the dissemination of EBPs designed to improve children's mental health by Novins et al. In 2013 showed that the vast majority of studies focused either on the preparation, about 26%, and implementation, about 82%, phases of Aaron et al. EPIS model, with very few focusing on sustainment, only about 11%. Post-September 11th, 2001, New York State was faced with a large percent of its population in need of mental health treatment and a mental health workforce very poorly prepared to meet those treatment needs. Through a partnership with Columbia University, the New York State Office of Mental Health launched a training program in cognitive behavioral therapy for childhood trauma. Mental health providers were trained and services were provided to over 400 children and families. The success of the post-9/11 training effort prompted New York State to develop a permanent infrastructure for training and evidence-based practices for children and adolescents in 2005. It was called, and it currently is called, the Evidence-Based Treatment Dissemination Center, EBTDC. No one actually says the title. EBTDC was designed to be a quality improvement initiative for the clinical workforce and licensed New York State Office of Mental Health agencies serving children and adolescents. That number varies between 330 and about 350, 360, depending on the day. Training is voluntary. There are no financial incentives offered to either clinicians or their agencies, although clinician-level certificates and, as of 2015, continuing education units are available for those who successfully complete trainings. Trainings initially were 3 days with bi-weekly phone consultations for up to 12 months. And from the inaugural trainings in 2006 through 2008, training was provided to 916 clinicians and 275 supervisors. Dropout rates were around 27.6% and 29.4% in years 1 and 2. In September 2013, EBTDC began training in managing and adapting practice. MAP was selected because it has broad coverage of client populations compared to single disorder-focused EBPs, and clinicians were, quite frankly, concerned about learning, 35 manualized therapies. It has clinician-friendly decision support tools with measurable outcomes, very important when you need to report outcomes. And it has been successfully implemented in numerous mental health care organizations across the United States. For those of you who are not familiar with Bruce and Eric's MAP, it is a system that's designed to guide and support clinicians in the selection, review, adaptation, or construction of treatments to match a client's needs. It consists of the practice-wise evidence-based service, an online service that can make recommendations about evidence-based programs or specific components of EBPs based on both the clinical problem and client characteristics, so it can be tailored. Practitioner guides that provide descriptions of a range of evidence-informed clinical interventions and their components, and a clinical dashboard, an Excel-based graphic display that tracks both outcomes, and the practices that a clinician is using. The initial training we developed was 5 days, followed by bi-weekly consultation calls for 9 months. 168 individuals registered, 154 initially attended, 140 provided consent to participate in the evaluation. 13 individuals were excluded because they were administrative personnel and didn't see patients. 64, or 51.2% of the initial training sample dropped out. Dropouts were older, completed few of the required consultation calls, prevented fewer MAP cases on calls, and were more likely to be from downstate urban areas rather than upstate rural areas. Anecdotal reports suggested that older clinicians had more difficulty with the technology demands of MAP. So, as was suggested in our last set of presentations, we needed to modify this. So we did, based on the data that we had collected. Given the unacceptable dropout rate, and it was unacceptable, several modifications were made to MAP training, and they were done, I want to say, in consultation with Bruce and Eric. They've been wonderful to work with. We shortened it to 4 in-person days, because remember, when we pull clinicians out for training, they don't bill. And 4 months of webinars with fewer clinicians on each webinar, thus encouraging, or we could say forcing, participation. Templates based on original clinical dashboards were constructed for different disorders with additional directions for entering and tracking information. Specific assessments for tracking were recommended but not required. Clinicians could use what they already were using in clinics. Recruitment was focused on OMH-identified clinics. Expectations for participation were made explicit, and the MAP website was updated with frequently asked questions, and we became much more aggressive about making sure people were comfortable with the technology. Training took place on version 2.0 between September 14, April 16, 128 of the 168 registered attending. Dropout was significantly lower, 12.3%. And the only significant predictor of dropout was a low rating on Greg Aaron's evidence-based practice attitude scale, the appeal subscale, but no information was collected on sustained use. So the objective of this study was to determine the sustained use of MAP and characteristics related to sustained use. Study population was 89 clinicians trained to proficiency in 2016. 9 to 18 months after completion of consultation webinars, clinicians were contacted via email up to 7 times, asked whether they were still using MAP and their reasons for use, non-use. 57.3% completed the survey. Pre-MAP, collect, and we do this for all of our training, sociodemographic variables, professional practice variables, Texas Christian University Survey of Organizational Functioning, Efficacy and Leadership Scales, and 3 in-house developed technology skills questions, basically, how comfortable are you with Excel? Post-didactic training and post-consultation webinars, we collected the evidence-based practice attitude scale by Aarons. We used the appeal, openness, and divergence subscales. Language the language was edited basically to ascertain clinicians' attitude towards MAP, specifically not evidence-based practices in general. Outcomes is continued use of MAP, 9 to 18 months. We did a series of analyses. So, First, given that I'm an epidemiologist, I had to see whether or not the full trained sample and the people that agreed to chat with us 9 to 18 months later were different. They are not different on any sociodemographic, practice, or professional service variable, as you can see. They are also not different on any of the on either of the TCU scales or the total score, the technology questions average, or why people chose to seek MAP training. So while it's the suboptimal response rate, they don't look different than the total sample. So what is our sustainability? Turns out it's 80.4%. The components that are still used, and used most frequently, are the practice guides, the clinical dashboards, and remember this was the one that was the bugaboo in the first round, and the P-Web search engine where they can seek out appropriate interventions. Barriers to sustainment were largely lack of time, and then 2 of the 9 other reading response was that their licenses with PracticeWise had expired and the clinics couldn't afford to get them. New York State is looking into that. And facilitators to sustainment were that it fits well with practice already in place, fits the needs of the population served by the organizations, and they found MAP to be a useful clinical tool. So then we said, okay, who did and did not sustain? Well, we looked at all the same characteristics, as you might guess. We have a pattern here. And again, there were no sociodemographic or practice characteristics that differentiated users from non-users. Neither were the reasons that they chose to seek MAP training, the TCU scales, or the evidence-based practice attitude scale directly after training. However, where we saw a difference was in the EBPAS total score 5 months post-training. That's at the end of the consultation webinar, and in particular, the appeal subscale. But remember, this was after both the didactic training and the focused clinical webinars that were consultation around using MAP. So we ran, of course, the standard logistic regressions, and it turns out that the appeal subscale, if you are high on the appeal subscale, you're 6 times more likely to continue using it, using MAP. This is, I want to comment on this, is 4 items, it's easy to give, it's quick, and it's turning out to be very important, both in terms of who drops out and who continues to use 9 to 18 months. It's an easy marker. So there are limitations to these data. This is a self-selected volunteer sample. And remember, the volunteer sample was also encouraged by the agency directors to sign up for this, so that it's even a little bit more self-selected. It was a suboptimal response rate to the follow-up survey. MAP use is self-reported, and there are no data on whether reported MAP use is related to improved client outcome. This is just simply whether or not they used it. However, we concluded that MAP adapt for use in a state system, and it was adapted twice, remember, successfully trained clinicians to fidelity, and 80% of those clinicians sustained use over 9 to 18 months. We also concluded that the 4-item appeal subscale of Greg Aaron's EPBAS can be used to identify clinicians who are likely to discontinue use and should be targeted for additional training. So I want to thank all of you for your attention, and here are the references.
Okay, excellent timing. Yes. Our next presenter is Jennifer Watling-Neal from Michigan State University.
Hi, I'm Jennifer Watling-Neal from Michigan State University. I am presenting some collaborative work with Zach Neal, who's in the back of the room. If you're interested in what we're presenting today, Zach also has some handouts, so you can approach him. Zach, if you want to wave, just so people know where you are. The project is the Michigan School Program Information Project, and I'll be presenting today on information brokerage between K-12 educators and mental health service researchers. So just some background on the MySpy project and what our research aims are. We're really interested in the potential for public schools as a venue for mental health service delivery. And the reason for this is public schools serve and enroll over 50 million US kids. So there's a tremendous amount of ability to reach kids here. But one thing that we know is that public school educators oftentimes can't access research. There is a research practice gap, as there is in many different areas. So educators are not speaking specifically to mental health service researchers. However, we know from our research and from others' research that educators are going to other people when they are thinking about implementing programs and practices geared towards mental health services in their schools, things like services around autism or services around suicide prevention and bullying. So they might go to other principals that they know, that they trust in their district. They might go to consultants. They might go to a variety of other people. And those people also go to other people. And then what we oftentimes see is brokerage, or sort of long, stringy chains of information seeking that are going on here. So an educator might eventually link to a mental health service researcher through their social network. And in our project, we were really interested in understanding these chains of information seeking that occur, and whether they eventually link educators to mental health service researchers, and what types of brokerage are most effective for doing that. And so that's what I'm going to be presenting today. So in particular, we were really interested in whether certain types of brokerage structures link educators and mental health service researchers. And we used a typology from some sociologists, Gould and Fernandez. They really broke brokerage down into three-person structures, right, where you have an information seeker, a broker, and an information source. And if you look at these three-person structures, there are really 5 ways that information can move from person 1, the information seeker, to person 3, the information source, via a broker. And these 5 different ways depend on which subgroups persons 1, 2, and 3 come from. So subgroups are just simply sets of people who engage in similar activities and who have similar interests. So you can think of K-12 educators, for example, as one subgroup, right? Their interest is in educating kids. They spend their time in classrooms teaching. If they are decision makers, they are looking at programs and practices to implement in their schools. Researchers, on the other hand, are a completely different type of subgroup. Right? So as researchers, we're oftentimes interested in generalizable knowledge, and we might be interested in improving mental health services for a large set of kids, but ultimately our activities are really different. We are writing grants, we are sitting around in conferences, and we're doing a lot of things that are pretty different from K-12 educators. So these 5 types of brokerage that you see here come from the Gould and Fernandez typology. Here we have the dots represent people, the lines represent information transfer, and the colors represent subgroups. And I'm going to talk about these different types in sets here. The first set I'm going to focus on are coordinator and itinerant brokerage. So coordinator and itinerant brokerage occur when person 1, the information seeker, and person 3, information source, belong to the same subgroup. So ultimately, we don't see information transferring between subgroups here. The only thing that differs is that in the coordinator case, everybody's in the same subgroup. This might happen if K-12 educators are just talking amongst themselves. Person 1 goes to a colleague who then brokers information to another colleague, maybe in the same school. Itinerant brokerage happens when the broker happens to be in a different subgroup. So maybe an educator goes to a consultant who knows a lot about mental health services. But then that consultant says, well, why don't you talk to this principal in another school that's implementing this new service, right? So it links them right back into the same educator subgroup. We thought that these types of brokerage, if they appeared in educators' network chains, would be less likely to ultimately link educators and researchers. And the reason for this is that they're not ultimately transferring information between different types of subgroups. The other three types of brokerage, though, that occur in Gould and Fernandez typology, gatekeeper, representative, and liaison brokerage, do transfer information between an information seeker and an information source who are in different subgroups. Gatekeeper brokerage happens when an information source goes automatically to someone in a different subgroup, and then that they sort of stay outside. Representative is the exact opposite of that. Liaison brokerage, we think, is the most interesting, because here, the information seeker is in one subgroup, the broker is in a different subgroup, and the information source is still in a third subgroup. So here we see information transferring across a lot of different subgroups in a short period of time, just between 3 people. And we think these types of brokerage might be most likely to link educators and researchers, because you see information hopping between different subgroups of people who have different sets of information. So to study this, we randomly sampled principals and superintendents across the state of Michigan. We have a representative sample of these principals and superintendents. And we asked them a question. We said, if you were looking for information about social skills programs, who would you talk to or where would you go first? And here we had a definition of social skills programs that included mental health service type programs. And then what we did is we looked at the person that they named, and we went to them, and we asked them the same exact question. So we asked them, if you were looking for information about social skills programs, who would you talk to, or where would you go first? And we had an overall response rate here of 74%. We've repeated this process for up to 6 waves. And that gave us a sample of 140 educators across the state of Michigan. Again, these are principals and superintendents, and 293 brokers that incurred their information-seeking chains. The resulting data were sort of these network chains that educators use to search for information. So you saw multiple instances of those 3-person brokerage instances that I showed you earlier, and these chains, and some of these chains successfully reached mental health researchers, and others did not. So the next thing we did with the data is we took all of our educators and all of our brokers in the data, and we coded them into 11 different subgroups. 11 different sets of people with similar interests and activities. Subgroups might be things like professional associations that serve educators. Sometimes they work with things like youth development organizations. And these subgroup codes were used to determine those 5 brokerage types from that typology I showed you earlier. We also needed to know, did an educator's network chain successfully link them to a researcher in the end or not? So we had to define a researcher, which is actually a little bit harder than you might think it is. We used a pretty traditional definition here as a person who holds a post-MA degree and who's published in a peer-reviewed journal in the past 10 years, or someone who's employed as a professor. So just some results here. What you see here is a chi-square analysis, and this is by a successful versus unsuccessful chain for an educator, and whether coordinator brokerage appeared, itinerant, gatekeeper, representative, and liaison brokerage. The chi-square was significant, and what you see is consistent with our hypothesis. Coordinator and itinerant brokerage were fairly underrepresented in successful chains. So you can see that when a chain had a coordinator brokerage in it, only 28.7% were successful. Itinerant brokerage was even lower. And also, liaison brokerage was overrepresented in successful chains. But we wanted to kind of break this down a little bit further. So what we also did is we ran some logistic regressions. So these logistic regressions, the outcome variable was whether a chain was successful or not. And we used the predictor variable, whether there was any coordinator brokerage, any itinerant brokerage, gatekeeper brokerage, and so on in the chain. And I'm going to show you the results of that as well. So here are these logistic regressions. I'm only going to talk about the ones that were significant here. So itinerant brokerage was really, really interesting If an educator had itinerant brokerage in the chain of information that they were using to search for programs and practices, they were 5 times less likely to ultimately link to a researcher. So if you remember, itinerant brokerage is this type of brokerage where an educator might go to somebody outside of their subgroup, but then that person ultimately links them to someone back inside their subgroup. This is particularly bad at bridging the research practice gap. So something we wouldn't want to see. Representative brokerage, on the other hand, was a good thing for bridging the research practice gap. So when educators had representative brokerage in their network chain, they were over 2 times more likely to ultimately reach a mental health services researcher. And again, this is one of those types of brokerage where we see educators ultimately kind of moving into a different subgroup in their network chain. And then liaison brokerage was the best case scenario for educators. So when educators had a form of liaison brokerage in the network chain that they were using to search for information, they were over 3 times more likely to ultimately link to a researcher. So again, liaison brokerage is particularly good because you see hops between multiple types of subgroups here. So this was particularly good at bridging the research practice gap for these educators. So where does this leave us? We're now thinking about interventions, and we're particularly interested in liaison brokerage because it's particularly effective for transferring information between mental health service researchers and educators. And in particular, we're in the process of trying to develop a network-based intervention where we can focus on identifying and leveraging individuals who can serve as liaison brokers between mental health service researchers and educators, engaging subgroups that are prone to having individuals that participate in liaison brokerage. In particular, in Michigan, for example, people in county-level educational offices are oftentimes in these liaison broker roles. And so if we can link educators to their county-level people, that oftentimes is an effective way to get them to research. And finally, we're interested in helping educators search their networks more efficiently and effectively to find brokers that will link them to mental health service research and mental health service researchers. So those are the things on the horizon for us. And before I end, I just want to thank my other co-authors and our funders, the WT Grant Foundation, and also the National Institute of Mental Health. And I'll stop there.
Okay, our next presentation team is comprised of Ken Wells and Placidia Williams, who are representing a partnership between research and community in Los Angeles.
No, I just got to pull it up just a second. Okay. Okay, I'm Ken Wells, and I'm linking my arm and your arm as a witness for wellness.
Hi, my name is Placidia Williams, and I'm linking my arm and your arm as a witness for wellness. And we're all going to do this.
Take a moment,
So get
link your arm to a neighbor, and introduce yourself as a witness for wellness.
Sally Horowitz.
There you go.
Almost does.
Did they reach? Oh, okay.
Yeah, they did.
Okay, we always do that because we want you to know this is a collaboration. We're engaging, and we don't want to just talk. We want to collaborate.
And we also are doing this on behalf of the Community Partners in Care Council, and particularly Loretta Jones, whom a few of you may know, the CEO of Healthy African American Families, who helped, and actually it's her replacement for the title. You want to read that to us?
The title is Engagement and Endowment in Life.
Or translated for the research, effects of community engagement and planning versus resources for services and of social determinants on clinical and community-defined remission.
That's why community doesn't understand anything, because y'all get so technical.
Okay.
The background to we, us, and our Depression is the leading cause of disability worldwide. Collaborative care is a symptom approach to evidence-based depression care, but often not available in under-resourced communities where services may be sought in other sectors. Little is known about the independent contribution of community linkages to improving health and behavioral health outcomes, and that's SAMHSA 2012.
How, together, ready?
How can we translate the promise of high-quality depression care into better lives for our under-resourced communities of color today?
That's been the question that we've been working on over the last 15 years or so. And then we want to just talk briefly about the context for doing this work in engaging under-resourced communities in both services and research, given the historical legacy of research abuses and distrust in research and in health services in under-resourced areas. So the legacy of Tuskegee, for example, is still very much talked about every time we talk in South LA today. But community-based participatory research is recommended for all of us to build trust in research and services and promote co-leadership by members of population studied. And these are just some examples of some of the calls for action on research and policy side for using a CBPR approach. And our goal, in part through this trial funded by NIMH, was to figure out how to use that in the context of a rigorous randomized trial.
Because community doesn't trust researchers, because you're always coming into our areas, our communities, you get information and then you leave. You don't give us anything, you might say thank you and walk out, that's it. So we don't trust you.
So the approach that we used to do the work in that context is community-partnered participatory research. Mm-hmm. This is Loretta Jones on the slide with me. I look a little bit younger, and so does she relative to today. But there's a core set of principles, transparency, so that really, I mean, what I know about the budget, you know about the budget,
right.
But in the intervention, respect, work together, power sharing, so that every time I speak, it's with a community representative, and Denise knows I'll always say, well, I'm speaking, you know, and she says, yes, we know, right? Two-way knowledge exchange. It's not my expertise, it's our expertise in what we know together. And then there's a structure with a council that is co-chaired by community and academic partners, working groups, which you might call committees, that are working on the problems together, and then broader community forums. We do not proceed with a project without holding a meeting somewhat like this. There might be 70, 100, 200, 300 community members there, and we say, this is what we're thinking of doing. We've come up with this together. We've worked with our council. Have we got it right? And there will be input at that time. We may make adjustments. I may turn to Denise and say, we have to make these changes. Mm-hmm. And
she might not like the changes, but the problem, the concern is you're trying to get community involved. And so Ken has to convince her that she needs to make the changes. And if he can't,
you will.
Then I will. And if I can't, we recognize that she has a problem.
Okay. So very briefly, we're focusing in the talk today on long-term outcomes, but I think many of you probably don't know this, so we'll do a quick catch-up.
Quick.
So this is in two under-resourced communities in Los Angeles, South Los Angeles, Hollywood downtown, about 2 million residents in those two communities. We identified 95 programs in those communities that provided mental health, primary care, substance abuse, social services, homeless serving, faith-based programs, community centers, hair salons, exercise clubs. All of those were programs nominated by the community as terms of where I deal with my business and my issues. So if we're going to talk about depression, you have to include these places. These 95 programs were randomized to one of two implementation interventions for an expanded model of depression collaborative care. And the client study, then we went into those 95 locations that had been randomized and over roughly 3 days per location, screened people walking through the door or there if they were in a church meeting for depression. And 40, you can see about 4,500 individual adults were screened, and then 1,322 were eligible and enrolled. There was about a 96% agreement to be screened. And then if they enrolled, they were asked to complete baseline 6 and 12-month surveys in these programs. We'll talk about the interventions in just a second. And then an extension study was funded, which is part of what we'll talk about today. Among those eligible, about 60% participated, were still around and participated in 3-year follow-up, and then there was 4-year follow-up that was added on. I'll explain why that was added on. So this is the community's design for what I just said, and for the intervention. So you see in the upper left different kinds of services sectors, and then the coin toss randomized to either being supported by themselves as an individual agency in collaborative care, that's Resources for Services, or as a coalition working across the agencies together collaboratively to figure out how to fit collaborative care to the community.
We always worked as a team, and we had someone in the community that drew these pictures their way, and then academia put it in this so it could, it'll look a little bit more professional, but it was their ideal of doing this.
Right. So, and you see plus right up there on the right. So the two interventions, just to be a little concrete, the Resources for Services offered each program 12 to 14 webinars. There was a visit offered to primary care sites, referral for intensive supervision, for example, for CBT, and then this was all done by an expert team, also with a community outreach leader to enhance, and that was the control arm. The intervention arm, CEP, 4 months of biweekly coalition planning, tailored training across the sectors, co-led by community leaders and experts, formal collaboration agreements, and then some innovation funds for new ideas like Google would do to do innovations around fitting things to the community. This is just showing the classical collaborative care toolkit based on partners in care, we care, impact, and both arms had full access to internet flash drives, written copies, and that's what we were working to implement. This is the characteristics of the clients who were screened. Those who enrolled were even more disadvantaged because they were also depressed. You can see a very high rate of poverty, 85% African American or Latino, 50% uninsured, 16% currently homeless. Of the depressed who enrolled, 40% were currently homeless when they were enrolled.
Mm-hmm.
So very, very briefly on what's previously been published and talked about in other meetings, the orange is the coalition arm, the blue is the training arm for program by program. You can see there was a much higher rate of participation in evidence-based training if you were a program assigned to the more collaboration arm. And client outcomes. So at 6 months, what we found is of 2 primary outcomes. We had depression, which did not have a main effect because they both are depression collaborative care interventions, but there was a reduction in having a poor mental health related quality of life, the other primary outcome by the SF-12 measure. And then we had a set of pre-specified community prioritized outcomes. So there was a reduction in having multiple risk factors for chronic homelessness. There was a reduction in behavioral health hospitalization, increased physical activity, and increased in mental wellness, which was actually the community's #1 priority for outcomes. Over 12 months, there was some continued reduction in having poor mental health quality of life and reduction in behavioral health hospitalizations with some sensitivity to modeling in significance. This is just to show you the idea, the mental wellness on the right, the reduction in poor quality of life in 6 months. Here's the increase in physical activity, the reduction in multiple risk factors for homelessness, and here is the reduction in behavioral health hospitalization. You can see it's a pretty substantial percentage reduction, which is hard to do. The 3-year extension study, at 3 years, there was improved physical health quality of life, which was actually the community's hypothesis. They said, if my mental health gets together in the main part of the study, then I can get my physical health together. And continuing reduced inpatient hospitalization nights and greater use of community services at 3 months. And that was just published last year in Psychiatric Services. And then, and we got a rush. So then the community hypothesized, if my physical health gets better, then my mental health get better. So we decided to add 4-year follow-up to see if the community was right. And we just made it work with our finances. And then PLUS said, you think this is about depression, this is about our lives. So we also decided to look at social determinants. We did a series of nested models looking both at time to first remission and number of periods in remission in the first 3 years, and then at 4 years, what happened. And we looked both at remission in terms of no longer depressed by the PHQ, and then the community's definition, which is not depressed, not having poor mental health quality of life, or having some mental wellness. Very quickly, this is what we found. At 4 years, the coalition arm reduced both being in clinical or community-defined remission. Over 3 years, there was reduced time to first remission, and especially in women, reduced time to remission and persistence. Social determinants basically predicted persistence. Almost any time the intervention wasn't significant, social determinants were, which means they were kind of complementary. Here's the example of community-defined remission increasing at 4 years and clinical remission in the coalition arm. Here's the women's finding, where you see the increase on average in numbers of remission, but also decreased if you were worried about food or you had depressive disorder. So basically, the coalition model, it's an exploratory analysis, seems to have long-term, has promise for long-term remission, but also addressing social determinants over and above coalition effects would probably further improve outcomes, and seems to moderate the coalition effects. And plus, you want to give a quick word on your experience.
Let me just say quickly, I deal with depression, and I've been suicidal over 40 years ago. And when I got involved in this, everyone was talking, and I asked them how many dealt with depression. And my hand was the only one that went up. And so I told them they've been studying books. I come from personal experience. So Ken's been following me, and I've been working with them and telling my story, and I go into depth, but I'm out of time. But I just want to say that you need to be aware of the people that you're dealing with. They're just not things that you're getting information from. They are people, they have feelings, and they don't know what's going on, they don't understand, they're afraid. I didn't know that I was valuable until 4 years ago. I'm 69 years old. And so now that I have a voice, I talk everywhere I go. I present, I talk to researchers. I went to an emergency medicine doctor academy, and I talked to them, and I told them they don't deal with us as people, they deal with the illness. They deal with the problem that they're there for. So I'm saying that to say that all of you have a decision to make. Are you there because you have a title, you have some letters behind your name, or are you there because you're trying to help someone? God bless you. Thank you for listening. And this is us. This is
Ready?
we, us, and our.
Thank you.
Thank you so much.
Great, thank you. Our next presenter is William Garrett from Johns Hopkins University Bloomberg School of Public Health.
All right, good afternoon. I'm very pleased to be on this panel and to follow up that presentation as well. I'm going to be talking about an ongoing effort from a Baltimore community academic partnership actually called Baltimore Connect. And its goal is to strengthen, in one sense, to strengthen mental health capacity in community-based organizations. An initial step in this process was to do a qualitative formative research phase. And by formative research, I mean research done not for the sake of merely research and leave never coming back, but actually formative research for service improvement as well as for program design and implementation. I did this work with Lee Bone and Dr. Jin Ju from Johns Hopkins, and I'm also applying to psychiatry residencies myself at SUNY Downstate in Brooklyn. So I think most of us know that in the US we have a treatment gap where the number of people with estimated illness is way higher than the number actually in treatment, and that there are racial disparities where Black, Hispanic, Latino, and Asian populations have a much larger treatment gap. However, some studies have shown that people of color may prefer to access mental health care in non-psychiatry settings, including human or social service or spiritual and healing settings, which sort of ameliorates the disparity in treatment gap. And that community academic partnerships have evaluated and strengthened mental health capacity in these social service CBOs or community-based organizations in other cities, and they informed the one in Baltimore. So Baltimore Connect is a nonprofit since September 2017. It is the partnership. It's comprised of 23 networked East Baltimore CBOs that provide a variety of social services. None are primary care providers or mental health professionals. They provide drug and alcohol recovery, job training, food kitchen, etc., grief counseling. And the objective of Baltimore Connect is to better link social and healthcare services provided at Johns Hopkins to connect Baltimoreans to comprehensive and coordinated health and human services. Mental health is a priority of this Baltimore Connect. There are executive directors from 5 CBOs and then Johns Hopkins medicine and public health faculty and students. So as a public health student, I had the chance to be embedded in this subcommittee whose research objectives for this project were to determine where CBOs in Baltimore Connect are right now in terms of supporting their clients with either emotional distress or a defined mental health disorder, and then also to learn from CBO staff what they feel like they need to optimally implement evidence-based mental health services, and then finally to develop recommendations to inform future programs. So this was a qualitative study. We recruited individuals to interviews and focus groups, and with their consent, they were recorded and transcribed, coded. Baltimore Connect's also a self-sustaining collaborative, so they have monthly full committee and mental health subcommittee meetings. So at every phase of the research, from design to objectives to interim data presentations, we spoke with them, and took notes. These are the characteristics of the study participants and also the meeting attendees. So there were 2 arms to the actual methodology. The first was to develop recommendations to strengthen mental health programming. And the method we used to have topics for our interviews and focus groups were looking at other partnerships between community and academia to see what they studied within this realm. The topics are listed in the navy boxes on the right. They were, how do you as a CBO recognize clients with mental illness? What services do you provide in-house? What are your experiences referring to allied professional mental health providers? What do you see as the barriers to providing mental health care for your clients? And what are your suggestions for improvement both within your CBO and within the entire mental health system. This was a deductive process. Our interviews were open-ended, purposefully to capture perspectives and experiences outside of these topics to make sure that we weren't only bringing an academic bias to the table. So we did what I'm calling a thematic study as well in parallel to the programmatic study. This was an inductive process using grounded theory. And then finally, we synthesized the programmatic study findings as well as the thematic study findings. And the goal is to develop recommendations for strengthening mental health capacity that are really relevant and meaningful to the community-based organizations and actionable. So again, one big topic of conversation was how do you, as a CBO, recognize whether your clients are struggling with a mental health issue or emotional distress? And since we had a wide variety of organizations represented, we had a wide variety of responses, a continuum of different activities to recognize mental health problems. Some organizations, particularly the soup kitchens with a rotating door and a high volume of clients, said they really only observed people with unusual behaviors, like talking to themselves, or they seemed intoxicated or poorly groomed. But they didn't have a system to ultimately recognize whether there was a mental health diagnosis. Other CBOs stated that they conducted wide-ranging but non-specific intake interviews with their clients, in which case mental health might come up as an issue, or perhaps in the demeanor of their clients, they could say, oh, maybe they seem anxious or depressed, but really, again, no way to follow up. Some CBOs asked the targeted question to their clients at the intake process, like, do you have a mental health or substance use issue? And then finally, one CBO we spoke to had formal screening questionnaires that they used for depression and PTSD. And this was the closest that they got to a mental health diagnosis, but even then there was uncertainty whether, is this screening tool good for our population, and how do you follow up on a positive screen? Referrals was a big topic, like from a CBO to a mental health provider if that was deemed necessary. Again, there was like a diverse array of sort of systems in place and outcomes, but we did identify some variables that indicated whether or not a referral to a professional mental health provider might be effective. I'm not going to go over all these, but one big one was the CBO's staff's prior knowledge of a mental health provider. If there was a formal agreement, or if they'd heard from their own clients that had gone to the referral, whether or not it was a successful experience, that was a big component. And then finally, the characteristics of the mental health provider at the bottom there. If the CBO was going to refer to a provider that didn't accept insurance or Medicaid, then it wasn't going to be successful the vast majority of the time. Also, a lot of CBOs didn't want to refer their clients to mental health professionals that weren't seen as trusted in the community or culturally competent. Staff also identified barriers to addressing their clients' mental health needs. They're listed on the left. The right columns are various organizations we spoke to and the Connect meeting members. The checks indicate the barrier was acknowledged, and the double checks indicate they were significant. Unsurprisingly, unmet basic needs like housing, food, and income were a major barrier. Safety, I think we've heard a number of times today. Being a victim of a mugging or any sort of other violence, either on the street or by even the criminal justice system, was an unmet need that precluded the recipient of mental health care. Stigma in the community and internalized was a barrier, and then dissatisfaction with or mistrust of the mental health system. So what were the recommendations that the staff gave us? So they wanted appropriate screening tools for diagnosing, ones that fit for their population. Also, stronger co-coordination of social services with the healthcare system. They also really wanted a directory of providers that were trusted, importantly affordable, accessible, not an appointment 2 months from now, and culturally competent. They were interested in an anti-stigma campaign. They want more training in mental health, even if they've gotten it before, refresher trainings. you can't assume one training is enough. And then a lot of them wanted professionals at their CBO, not to have to refer out, but on site for one-on-one services. In the thematic study, in addition to providing tangible social services like food or income or financial assistance, in terms of mental health, they stress that it's really important for them to develop a relationship with their clients, to cultivate a reputation as a safe haven, as a house of healing, as really being community-based. And this was sort of a big, perhaps an even bigger outcome than sort of the number served. Additionally, a lot of staff felt that there was sort of a misconnect or a division, even a tension between their organization and the professional mental health system, which some perceived as having a definition of mental health that's too narrow and doesn't address environmental stressors or basic human needs, and might be better suited for middle-class people. I heard from one staff who's with isolated, potentially, mental health issues, not things like homelessness or worries about safety. And then also they discussed that there's a reputation in the mental health system of misdiagnosing, which creates a historical tension, especially in Baltimore. So to synthesize the two arms, they really, one of the strongest recommendations was training in the staff to help them both identify needs and to respond, but also to sort of break down the barrier that might be built if somebody is acting unusual or might have a diagnosis, to help strengthen their relationships with their clients through training on their end. And then having a psychiatrist or another mental health professional in the CBO teamed with the social workers and case managers to both diagnose and treat, but also bridge the physical divide between CBOs and the professional healthcare system, and also cultural divide. So in the spirit of a community academic partnership, I presented these findings back to Baltimore Connect, to the CBOs, with, which mostly consisted of executives and directors. They felt that the findings were both important and valid, and this year-long research process and final results spurred grant writing. And the mental health subcommittee of Baltimore Connect just got a foundation grant from the Kaler Foundation, and it has 3 components. We're in the planning process now. The first is a staff mental health training program, first in something called mental health first aid, but hopefully in something more intense in the future. Also a depression care facing clients in CBOs through a peer mentor program. And then for those with severe depression, in the CBO, care via a psychiatrist, video conference consultation, and potentially referral. So just in terms of this study, I feel strength is that we were hoping to align the recommendations to the actual CBO's perceptions and experiences and principles, and to minimize just doing this within academia. However, this is a small community sample, and this might not be generalizable to community-based organizations that don't have an organizational mission that is focused on mental health. They'd just be narrowly focused on what they do. And then the next steps in Baltimore Connect research could be to speak to more employees, also to the clients, to triangulate the findings, and also to potentially focus on a study topic of priority, not just mental health and substance use in general. And these are additional members from Baltimore Connect and Johns Hopkins that were helpful, that I would like to acknowledge. Thank you.
Okay, our final presenter is Rebecca Stewart from University of Pennsylvania.
No, I'm giving it away. Okay. I also realized that I brought the Italian lunch buffet up here with my notes, so that's helpful. I brought the menu for the lunch. No, I brought it up with me. I'm so excited to be here and to follow this panel is a tall ask. My name is Becca Stewart. I am from the Center for Mental Health Policy and Services Research from Penn. Together with the Center for Health Incentives and Behavioral Economics, we have an Alacrity grant that takes insights from behavioral economics and applies them to improve mental health services delivery. This funded 3 separate projects, one focused on the patient, one focused on the clinician, and one focused on the organization. Today I'm going to be talking about the organizational focused project, although we sample from clinicians. The reasoning for this project is pretty simple. For the last 5 years, our group has worked closely with provider agencies across Philadelphia with respect to their implementation of evidence-based practices. And one of our most striking findings is that clinicians report that they do not feel rewarded to do evidence-based practices. So there are payer incentives in the system currently that go to the organization, and that's largely where they stay. They don't go directly to the clinicians. So we were inspired by participatory design approaches that engage our end user, so in this case, the clinician, in developing implementation strategies for behavior change. So we proposed us to source clinicians directly and ask them, hey, how might your organization reward you or help you use evidence-based practices? We used a virtual innovation tournament to crowdsource clinician ideas. Innovation tournament, really an ideas tournament, think American Idol for ideas, systematically elicits a large number of ideas, and a handful are ultimately selected. So here it is. We used a platform called the Your Big Idea platform, and we spent a lot of time on the prompt, thinking about it, debating it, vetting this prompt with our stakeholders. And ultimately, we kept it broad so as to get the whole field of incentives and enhancements. So we sent out the document to clinicians as how can your agency help you use evidence-based practices, really focusing on how the organizational support can incent the clinician directly, which was the goal of this particular project. So if you look at the platform, you could not only submit an idea, you could vote and rate the other ideas that were already in. So our team did a lot of investigative work. We sent this out to 210 executive directors of organizations in Philadelphia that provide behavioral health services, 527 clinicians, and 3 or 4 relevant local listservs that we knew reached large swaths of the network. So after many spamming of reminders, we were thrilled to have 65 ideas from 55 clinicians, as well as 55 comments and 899 ratings of ideas. So the purpose of an innovation tournament really is to engage your community of interest, and I would say that we succeeded. And to our knowledge, this is the first time there's been a crowdsourcing of implementation strategies developed from clinicians themselves. So in addition to harnessing the engagement of clinicians, the end product is the pool of winning ideas that we're going to be using for further analyses. So what were the categories of solutions that were proposed? The first is train me. Over half the ideas involved training in some capacity, and this surprised us because the city of Philadelphia has invested heavily in supporting 5 different evidence-based practices, training over 1,000 clinicians in the last 5 years. And this is a population that is already very well trained, and yet the majority of the ideas still fell in the train me bucket. Another quarter of the ideas fell in supervise me. So a quarter of them wanted this related to evidence-based practice specific expert supervision. Prep me. So a fifth of the ideas related to tools. So like one-pagers, binders of treatments, evidence-based assessments, toolkits, video support. 40% of the ideas pertain to being compensated, rewarded, paid for their time and effort. As we all know, evidence-based practices are expensive. They're time-consuming. Not surprisingly, therapists want to be compensated and rewarded, recognized. So anything from a free training, a bonus for certification, a pizza party, to complicated reward schedules for fidelity. Now, for those of you who are advanced in math, you may have noticed that this is adding up to more than 100%. So we tried to keep it in clear buckets, but it was just too hard. So there were multifaceted ideas that were in Train Me and Comp Me. So we're going to noodle with some of the categories in a future date. So things were counted twice, basically. Support my clients. About 1 in 10 of the ideas involve supporting my clients. So providing childcare or changing the waiting room to make it less chaotic and relaxing, i.e. turn off the news. Change the organization and the system were the last 10%. These ideas included changing the climate of the organization or the leadership, and also ideas about the system, such as increasing lengths of stay in residential treatment or increasing public mental health funding. So here are the categories. How did we decide the winning ideas? We decided to form a challenge committee to decide the winners. This committee of policymakers and academics. These were members of the committee had an academic, economic, public policy, and administrative viewpoint. So our committee included the Commissioner of the Department of Behavioral Health, David Jones. We sent the committee the ideas. They voted on their enthusiasm for each of the ideas, specifically the idea's potential to increase therapists' use of evidence-based practice, and we designated the top 6 as the winning ideas or the winning innovators of our innovation tournament. So here is a table of the 6 highest ranked ideas. So remember, we have an N of 6 here, so don't be too dazzled by the data. Looks like the top 6 scores ranked between 3.5 and 4.3 on an enthusiasm scale. And again, these were the top ranked ideas by our Committee of Behavioral Economists, Administrators, and Policymakers. So the first idea, this was the waiting room idea I mentioned, proposed to change the climate of the waiting room and give clients a worksheet to complete, to prepare them and prep them and get them ready to do the work in the session ahead. The next idea proposed a network of expert evidence-based therapists with which to consult, like a 1-800 hotline. The third suggested a point-based system for evidence-based practice, fidelity, and rewards and tokens. The fourth surrounded incorporating assessment instruments into the EHR. The fifth idea focused on on-site training and consultation for evidence-based practices. And the last idea recommended an intra-agency community mentoring program to address clinician isolation and provide community therapists with a community of therapists with mentorship from other community therapists who are familiar with the population. So all 6 of our innovators met with our team over a working lunch. We helped them refine our ideas, and they put together a 3-minute pitch. In May, we hosted a community event featuring the innovators' presentations and a Q&A with the innovators and the challenge committee, and over 75 people attended our event. And one of the innovators had a social anxiety disorder, so we cured that with some public speaking exposure. So that was our innovation tournament and the closing of our tourney. So what's next? Well, we have these 65 ideas, and now it's time to develop some implementation strategies. So the data here are 65 ideas about how clinicians think their organizations can help them do evidence-based practices. So we're taking 2 roads down this analysis. They are both less traveled. This project has always been very fun in this way, very exploratory. Bernard Beta says, building the plane while we're flying it. So behind door 1, we're doing what is called behavioral design. The point of behavioral design is to think like an engineer and get a 360 view of the target behavior. If we want an intervention to change behavior, let's think about engineering an intervention using a behavioral lens through behavioral design. I'll have an example that will be more clear. Ideas 2 is one framework for behavioral design that we're using. So we've defined the problem. The behavior is that therapists are not using evidence-based practices in session. So in the diagnosis process, we use the ideas and we generate hypotheses for behavioral reasons why the problem may be occurring. So we're using the raw ideas to generate hypotheses about barriers that these 65 ideas are proposing to solve. So, for example, the subset of ideas, there was a subset of ideas that address the problem that EBPs are complex, multifaceted, multi-component, multi-step practices. They're overwhelming, they're hard. Through behavioral diagnosis, we generated hypotheses about the behavioral barrier. EBPs are hard, and I don't know where to start, so I don't start at all. I'm an ostrich. So we've begun to think about designing strategies to address this problem, things like checklists, toolkits, or even debiasing functional fixedness, or the belief that EBPs should only be used if they can be applied exactly as intended, exactly as designed, and in their entirety. Otherwise, I do them not at all. Ultimately, this behavioral design process will illuminate 5 to 10 different behavioral bottlenecks that can be used to develop implementation strategies, and this will happen in our next forthcoming design stage. Back to our other road, less traveled. This is more well-known probably to most of you. We're going to go back to 65 ideas, and these ideas will seed a discrete choice experiment among the different incentive strategies proposed. So we will pit different attributes and different levels of the strategies that were designed directly from the raw data, and we'll test them with 4 stakeholder groups: clinicians, agency leaders, policymakers, and payers. So those are our 2 roads for crunching these data, and thank you for listening and your attention to the results of the Philly Crowdsourcing Challenge. Thank you.
Okay, we want to open it up for questions. We had a diversity here of types of partnerships with community, with non-mental health providers, with human services providers.
I'd just like to say something since we don't have any questions. What I liked about what we did was not only did they involve me, we brought in other community people, and through me being involved since 2003, I've learned how to deal with my depression, what depression is. I've learned all about all of mental illness, mental wellness. We don't say depression, we don't say all that. We give it different words because we don't want to deal with the stigma. And it has changed my life completely. And now I can talk about it. I'm not ashamed of it anymore. I now know what I'm talking about. And it has changed other people's lives also. And they want to be involved with us. And we had some people that wanted to come to this conference, a mental health conference. I said, I didn't know they had one either. And so, but they can't pay for everybody. But the bottom line is that when you want to, if you truly want to do community engagement, then bring in the community and find out what they're thinking, what is necessary for them. You'll be surprised how it changes what you're trying to do and help you enhance what you're trying to do. We had to convince everybody, because if you look at Ken, he's not the same color as me, although I'm light complected. They didn't want to deal with Ken because he was not African American. And so I said, Ken, explain to me what am I doing at this? This is when we did the Witness for Wellness. You probably remember that program. And I said, Ken, what are we doing with this group? And so he explained it to me, and I said, when I get out of line, help me. And so it took them, 3 months before they started trusting Ken because he wasn't their color. And they started talking to him, and we wanted to get the survey, the PHQ-9 survey. And that's what we used, but that's not the one we chose. And they were upset because Ken said, we can't use that because they're going to charge us for that. And they was like pissed off. They were like, see, we told you that white man, blah, 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 blah. I said, no, wait a minute. So I had to explain to them the importance of what Ken was trying to do. But I'm saying all that to say not to be racist or anything like that. I'm saying that because you need to know your environment, the people that you're dealing with. You need to know where they come from. You need to know, we did a study on parental guidance or whatever. You need to know what's in their head. What are they thinking about you and the project that you're doing? Because we are afraid. We don't understand it. We've never been exposed to it. And since now I know I have resources, when I go to the doctor now, my doctor sits down with me. He doesn't walk in and say, okay, this is the results and and out. No. I know you're supposed to be there 15 minutes or less. He sits down with me now because I know what's available to me. And so now I'm teaching other people. And now I'm teaching doctors, not only researchers, but doctors how to deal with patients. I'm sorry, I wasn't supposed to take that much time.
Well, since there isn't another question yet, I wanted to ask the view, do you have some thoughts about why you had such success with women that was part of your
That's
data?
before he had all the hair. He got a little bit more weight.
No, but there were better outcomes, or there were noteworthy outcomes for women?
Yeah, well, I think in general, one of the things that we learned is men, especially minority men, are harder to engage. Mm-hmm. I mean, we have a separate paper on men, and there were somewhat different portfolio of outcomes. So the depression outcomes tended to improve more in women. They engaged more in the care. For men, it was more the homelessness outcomes or hospitalization outcomes. So it's to some extent, the outcomes we were focusing on in the study, but definitely there were different issues. One of the things that we had to do, for example, to the PHQ-9 in the study was to have alternative items without the word depression, and we did that for minority men, and lo and behold, some men only got in because of the version without the use of the word depression in the study. So the community was absolutely right about the changes needed to age. So I think that's part of it is engagement, and part of it is somewhat different portfolio of outcomes. Yeah.
Interesting. Yeah. Okay, question here. Can you come to the microphone? 'Cause the video cast people can only hear through the microphone.
Hi, thank you so much to all the presenters. I'm fairly new to the world of research in the real world. I only just graduated with my MPH fairly recently. Thank you. And it seems like all of you have been working with different research populations, either largely minority communities or teachers or clinicians, but all of your projects emphasized if we need to work with this specific group, we need to ask them what they need from us.
Absolutely.
But I get the sense that that's relatively new when it comes to research. One of you emphasized that we can't let our academic bias shape the way that we're shaping our projects. Is the way that I understood that kind of accurate? Is that a newer trend in research from those of you who are more experienced than me? Or is that kind of a misunderstanding on my part?
So I honestly don't think it's a newer trend. I think that it's gotten a lot more emphasis over the last 10 years, let's put it that way. You know, I mean, even something as easy as training community-based clinicians is not easy, because when you really take a look at it, you're pulling people out of their practices. That costs a fortune. You then need to give them supervision so they feel comfortable using it. So if you can't reconstruct what are sort of, you know, the off-the-shelf kind of version of all of this so that it meets those needs, and you heard that consistently no matter who spoke, basically. And I think it's just something we've become much more cognizant of, but it's been around forever.
Yeah, and I think also with the growth of dissemination and implementation science and the realization that a lot of our practices are not being used by the populations, and that there's a lot more interest in understanding the population's perspective.
Thank you.
Yeah, maybe just one other comment on that. You know, there are two issues. One is the stakeholder engagement, and that, you know, CBPR has been around for a long period of time. The other issue is, you know, breaking down the silos across sectors, right? Whether it's education and health, or health and social services, and I think what you tend to see is there are certain areas, either conditions or populations, where maybe people have been working on that, and others where it's newer, right? So what I think you hear is that we're trying to apply both the silo breaking down and the engagement of stakeholders as broadly as possible, because there are so many needs out there, whether it's kids or systems or training or addressing disparities. So we're trying to share, you know, together what are these different tools that can be useful.
Okay, Andrea, and then come to the mic. Yeah.
I'm gonna adapt. Life is all about adaptation, right? So thank you for the panel. It was really nice, and it was really nice to hear everybody addressing different aspects of disparities. I have a question for Joaquin Kennedy. Sorry. When you were saying about your measures about social determinants of health, I was just thinking about it, something that we are thinking a lot also at NIH, how we are doing this in research. And so I want to know how you also address those variables, also asking in the community what variables were important to be addressed.
Sure. What we examined everything from food insecurity to financial problems, jobs, stigma, social isolation, substance use, and so forth. So the way we had our own framing, you might say from a socio-ecological perspective, but then we also met with community to prioritize. And in fact, here's an example. The week before we were going into the field, we had already prioritized with the community that homelessness was one of the issues they were especially concerned about. And we had a meeting where people were looking over our surveys, to give feedback. And they said, well, where are the measures of homelessness? You have health in there, you have depression. There's no homelessness measures. So I turned to my colleague, Kathy Sherborne. I said, we have 2 days before this had to be printed. So she did this huge literature review and so forth, and the reason, and it turns out we had a main outcome, effect on risk factors for homelessness. So the community, input was critical to not only identifying social factors, but literally even measuring them. But yeah.
Yes, my question was about something that you mentioned, Ms. Williams, which was that community members wanted to come here to the conference, and I wonder if anyone's had experience or if you've had the conference come to the community. I used to work with the Alaska Area Specimen Bank, and one of the requirements for working with the data set was that there was an annual conference day in which everyone who worked with the data made a poster and presented it, and everybody was invited to attend, and it was one of the most valuable experiences I've had as a researcher.
I think that we give conferences, we do five to six a year. We do kidney, we do depression, we do cancer, autism, whatever. These are things that we got from the community that we need access to, that we don't understand, we don't know about them, whatever. And so, and the conferences are free. We serve breakfast and we serve lunch. And also we ask for donations so we can do raffles and have them fill out the surveys, because we know people leave after they eat, they don't want to do whatever. But anyway, so we bring the conference to them, and they are educated. I'm an educator by nature. I found that out a couple of years ago. Everything I do, I try to educate, and I'm always teaching and doing stories and stuff like that. But that's what we had to do in order to get them involved. And then they said, "Oh wow, well, how have you thought about this? Have you thought about that?" And his brain is working right now. Trust me, he's got a whole bunch of notes on this paper, because he's steadily thinking of how can we do this and how can we do that to help the community. He needs his information for his researchers, but he also needs for us to learn also. So I think that's what we've done, is bring the conferences, workshops, whatever. We do workshops, we do symposiums. We had them at churches. We have churches now. We have different organizations that say, "Oh, you guys are here? Okay, good," because their people get to come, and it's open to everybody. It's not open to, and we do surveys to see who's at those conferences. Are they educated, uneducated? Do they have degrees? Do they have the illness that we're dealing with at the particular? We have August 16th. We're doing the cancer conference, and after the conference is over, 2 or 3 or 4 weeks later, we're going to have the committee that put that conference together and say what the answers were to the survey, so we'll know what to look for the next time. So we constantly are back and forth, changing, exchanging, and that's what Loretta has taught Ken. I know that she taught him, and then he taught her about the academic part of it. But they've worked together as a team, and they did a thing where we did a marriage or whatever. And so I'm his other woman, because she couldn't be here today. So anyway, but yeah, we do that as in collaboration. And I was glad to hear that you try to bring in others, and because that's important. It's not just. And I asked William about a question. He said that is their screening good enough? What do you mean, are the screening good enough? You know what I mean? If he's asking only CBOs, you haven't asked the community, is it good enough? You understand what I'm saying? I'm not putting CBOs down. I'm not putting them down. I'm saying, if you want to know that, you need to ask the people you're screening or you're talking to. I don't know if I answered your question or not.
It's making the research much more complex, right? We have to look kind of
Yeah.
360 degrees to see the stakeholders. I think Chris had a question.
For Rebecca, I was just wondering how easy was the crowdsourcing website that you used in creating the questions and putting together the forms and sending them out? And then for William, I was sort of curious, you know, a lot of community mental health centers or community-based mental health providers in mid-sized towns or rural settings, they're not likely to be new ones coming into town. Their reputation is sort of sealed at this point. And so for a CBO who then decides that the community mental health center or the local mental health provider is not a good player, what do they do? Do they have any sense about how to undo that reputation or how to change the reputation? So that's a little bit more complex than Rebecca's question. But Rebecca, I'm curious to hear about the website too.
It was a great platform. I recommend it highly. It was powered through Penn Medicine, so there was someone on Penn Medicine staff that really helped us. And then through our work in the community, we did have lists of, so it was a lot of work on our team in terms of compiling the list, but it seemed pretty seamless in terms of the website.
So it was like SurveyMonkey or something.
Yes.
Nice. Thank you.
So let me make sure I understand the question. So you're saying if a community mental health provider develops a bad reputation and they might be the only one, what do you do?
What do you do? Because these guys are saying, like, they're saying, hey, listen, I don't want to damage my reputation with clients by suggesting that you go to another provider, community mental health provider or mental health provider who has a poor reputation. So they're not going to make the referral. But that may be the only person, the only provider in town may be that person that has the bad reputation. So what do they do?
Well, I think one of the suggestions from the community-based organization staff is let's strengthen the mental health capacity in the CBO so we don't even have to worry about the referral where a million things can go wrong. And so they're clamoring for mental health professionals in the community-based organization. With regards to the damaged reputation of the providers, I think that's difficult. I mean, I was working in an urban setting where there were, I guess, a multitude of potential options. But I think in a rural setting, that's even more difficult.
Yeah, very interesting, sort of like integrated care amongst healthcare. The healthcare providers are saying, we'll just take over the mental health piece. So thank you very much. Great answers.
Yeah.
Okay, well, very good. Very interesting, very much for our whole panel.